So we're going to talk about the kind of monopolar stimulus first. Like MEPs, you're going to do anodal stimulation. And the stimulus delivered directly to the brain surface, and you get a compound muscle action potential, wherever you've placed your EMG electrodes. But you never want to go above 20 milliamps. And it's going to be one-sided. So like in cases that we do is we generally, if we're doing that type of stimulus and we're doing for monitoring purposes, we'll run a control motor at the beginning, like a transcranial motor at the beginning of the case and see if we can get it. But we don't use that during the case. We just use a strip. We just have it just in case something happens with the strip or something happens, we need to troubleshoot. But because it just creates so much movement sometimes that the strip is if you get it to work, it's awesome. So basically monopolar stimulation hyperpolarizes motor dendrites, activating cortical spinal volleys much easier and faster in anesthetized patients. Bipolar stimulation will require more current, more time. If you're doing, have you guys ever been in a speech mapping case, any of you? They hold down the stimulus 2 to 4 seconds. It's not a one-shot deal. They hold it on there for 2 seconds or 4 seconds, and they take it off. Because you need more time with bipolar because you're not getting the current, you're not getting enough current out. Monopolar is more sensitive stimulation and the response is more robust. I've only done the bipolar stimulation in awake craniotomies. That's the only time I've ever done it. Basically, this is what these motor potentials look like this was an XL Tech machine, but this is what they should kind of look like. So you can map, like I said, the homunculus, and you can see here, we mapped it, face, arm, hands, and then S is for sensory, M is for motor. Well, I'll go into this more in detail in a little case study that we do. But basically, you just put the strip down and you stimulate it. And they can put it this way, any way, and the surgeon will tell you what contact to use, and you stimulate it. That is the one kind of pain for these types of surgeries, is that when you're using the strip, there's 6 outputs, right? 6 touch-proof ends. But you're only using one channel of stimulus. Unlike the phase reversal, where you're plugged into 6 acquisition spots, with this, you're using one channel on the ES9. And by using one channel on the ES9, if he goes stimulates from contact 1, and you go, okay, stimulate contact 1, and you go stimulate contact 3, you have to get up and go and change it out. I guess you could set up 6 ES9 channels to stimulate, but that's painful too. So just keep that in mind. So what I used to always do is try to have 2 people on these cases for that reason. Somebody to kind of be a runner and help plug and unplug and things of that nature, because depending on the room, but I've done these by myself too. And the surgeon's aware. You jump up, you go, you do your thing, come back, you hit it. What's nice is that when you hit it, it's like a motor. It happens immediately.
So obviously you got to know that this kind of case you're doing, so your recording electrodes are throughout the body, right?
What's that?
Your recording electrodes would have to be throughout the body.
I missed your first part of your question.
So you'd have to know that you were doing this prior to that you were going to try to do this motors and have your recording electrodes at the face, at the hand, just like you would for transcranial motors, right?
Yeah, but you only cover one side. Right. So unlike regular transcranial motors, you're only going to cover the contralateral side to where you're stimulating. But you cover, usually not so much the face, it happens, but usually arms, legs. You want to cover everything because you never know where you're going to end up being. And then again, the functional monitoring where you're stimulating the entire time. So once you've mapped it, they leave the strip in and you're able to just kind of, and what's nice is that, because if you guys know in these surgeries, You're running SCPs, you might be running SCP every hour because they're quarterizing the entire time, right? You can't get an average in. But with a motor, and the patients don't move with these motors, which is nice. So as soon as they stop the cautery, you can hit a motor like that. And you can monitor the entire case and not wait that hour, 2 hours to run SCPs. So monopolar, similar to transcranial motors, use contralateral upper extremity and lower extremities. And if the surgeon's worried about the face, you'd add some facial muscles. Stim intensity between 10 and 20. I go right to 12 or 15 right away. Pulse train 4 to 9, and a duration of 500 microseconds. So this was an interesting case that I actually, we published this case study. 22-year-old male, he was 5'8", 54 kilograms, no past medical history, and no neurological problems, presents to the hospital with status epilepticus that lasted for 4 weeks prior to being brought to the operating room, specific to left face and left upper extremity tremors. So basically, they had no issues, and they presented basically in a seizure coma for 4 weeks with arm and facial tremors. Prior to the onset of seizures, the patient demonstrated no symptoms with the exception of a headache the day before. The differential diagnosis is encephalitis due to an unknown viral infection, and a craniotomy is performed to localize the focal point of the seizure. So what we did to monitor this is we mapped the brain using sensory motor localization with phase reversal and direct cortical stimulation. The first was to differentiate the motor and sensory cortices by utilizing a somatosensory evoked potential, and the latter is used to identify eloquent cortex and verify safe zones that can be potentially resected or subpeeled without adverse neurological deficits postoperatively. So this was an epilepsy surgery. They were looking for the focus, and subpeeling is, like I said, they peel into the brain tissue, see if they can get rid of it. Direct cortical stimulation allowed the surgeon to map the functional anatomy of the precentral gyrus. So the patient's placed in a supine position, the head's turned 90 degrees, and the head's fixated with pins and a Mayfield head holder. A bump is placed on the patient's right shoulder to help in the rotation, so they just kind of bump them up. One thing I forgot to mention about when you're doing direct cortical stimulation with a strip, like a triggered EMG, you need another reference electrode. So we usually put one right behind the ear. And that's your negative. Okay? Yeah, just put it right. Just want it out of the way. As long as it's out of the way, just put it, because remember, it's all it is a reference electrode. So craniotomy is performed, skin flap is made, the bone plate's removed over the lateral section of the skull on the right side. The dura mater is peeled back, and a 1x6 strip electrode, subdural strip electrode for acquisition of somatosensory evoked responses is placed for sensory motor localization. So this is under the microscope. You can see the strip going down. What you want to keep in mind about the strip is that they're usually numbered, and you want to make sure those numbers are up. Numbers facing you, facing the surgeon. The downside is the contact. Each contact of the subdural electrode is referenced to FZ of the 1020 system. So, just go back real quick. This is the reference for direct cortical stimulation. If you're just doing a phase reversal, you don't need that, because you're just going to reference off you're already at the FZ is already there for your SCPs. So I don't want to confuse the two. They're two separate modalities. You can use the same strip, but you have to keep that in mind. If you have the strip in 6 inputs in your acquisition box, when you go to stimulate, you have to unplug that and plug it into your ES9, which should have the extra lead coming down and plugged into the negative of the stimulus. Does that make sense? Stimulation electrodes were placed over the left median nerve at the wrist. contralateral to the site of lesion, and we delivered our, in this case, we stimmed transcutaneously at 25 milliamps. We use needle electrodes to stimulate with a sweep trial of 1,000 trials and duration of 0.20 milliseconds or 0.2 milliseconds and a rep rate of 4.7 hertz. We were able to get a total intravenous anesthesia of propofol, sufentanil, and ketamine with no muscle relaxant on board. Remember, these are going to be affected like an MEP or like an SCP. The anesthesiologist, we had placed a soft bite block for protection of the tongue and endotracheal tube, and we had cold saline available on the sterile field in case a new onset seizure was induced due to direct cortical stimulation. A baseline phase reversal was obtained with sensory cortex being represented from contacts 1 and 2, and the motor cortex being represented by 3 through 6. So 1 and 2, sensory, 3 through 6, motor. Once the baseline was established, the surgeon proceeds to move the strip posteriorly, where the phase reversal is found between contacts 3 and 4. So they move the strip posteriorly, and now sensory, sensory. This is probably closest to the central sulcus, because you see how it diminishes here exponentially, and then motor cortex. And I'm sorry, guys, the green is going to be the baseline here. So try and take the green out and just picture this, I guess, black or blue line. So this is probably the closest to the central sulcus, and then this is the motor. 4, 5, and then 6 is off the screen here.
So that's just the most definitive, like, reversal. Because I would have kind of called it the next one up.
Call this reversal?
In between that one and the next one. Because they're going opposite ways, you know what I'm saying?
But not really, because you can still see the peak here.
Okay.
See that?
Yeah.
And for the exam, for like the CNIM, what they always do, and I think I've seen this once. If your electrode ends up on the central sulcus, you'll get a flat line. And that's what they show in the CNIM. I've only seen it I think once. But that's kind of like getting close to flat. But you can see definitive difference between this and that.
Yes.
And that's how I knew that that's where it was. Strip was moved now laterally. And all that did was kept the phase reversal between 3 and 4. So here's 3 and here's 4. And all they did was take the strip from more almost, here and just moved it out laterally. Next, the electrode was moved anteriorly, which indicates the phase reversal now between contacts 2 and 3. So the strip was moved, and the orientation is important. 1 was going posteriorly and 6 is going anteriorly. So as they push it anteriorly, we get between 2 and 3 the reversal. Surgeon takes the strip off the brain, reverses how it sits now. So remember we had 1 down here, now 1 is up here, reverses it, and then we obtain sensory responses from contacts 1 and 2 with no responses from 3 through 6. So that was this. Oh, and there's your answer. That was a phase reversal, April. It was this case. So they reversed it. But again, I want to keep this in mind. When them reversing that strip isn't going to change your polarity of your SCP. That doesn't change. One that changes is where the motor might show up. So technically, if we were over motor cortex, it would end up, up here, and the sensory be down here, but it'd still be the same polarity. Surgeon places the electrode in its initial direction, so he turns it around again, moves the strip anteriorly, and a phase reversal is identified between 4 and 5. So now you see we have 1, 2, 3, 4, and you can see 2 and 3 are probably the most on the sensory cortex because they're the biggest responses. 3 starts to come down, and then 4 is motor. So after we did all this phase reversal, and this could be, depending on the case, this could be an hour, this can be 2 hours, this can be 10 minutes. It all depends on the surgeon, how comfortable he is, how much he wants, how much information he needs. But I've done just that for hours. Direct cortical stimulation, we use the same strip. So we didn't put another strip on the field. And this is where you went into the box, right? So if we go back, I'm just going to go back to the initial setup, sorry. So here we're 1 through 6 in acquisition, right? You guys remember what the old catalogs look like. 1 through 6 here, acquisition. Now we're in the ES9, or the old version of the ES9. And so, like for example, here I have 5 plugged in, and then I have the reference, right? That secondary electrode is my negative. So remember that the strip itself is going to be the anode, and that stimulator reference is going to be your cathode. And I try to I put it out of the way, usually at the base, right at the base of the skull. It's fine. So we use a pulse train stimulus delivered at 15 milliamps with a 500 microsecond duration. Needle electrodes were placed in various musculature, contralateral to the side of the lesion. These muscles include the left oris muscle in the face, the left biceps, the left flexor carpi radialis in the forearm, the left abductor pollicis brevis in the hand, the left vastus lateralis in the upper leg, and the left tibialis anterior in the lower leg. And I've highlighted all of the muscles that we used here. So oris, biceps, flexor carpi radialis, APB, vastus lateralis, tibialis anterior. After the final phase reversal, indicating the motor cortex being represented under contact 5, we started our DCS with contact 5. We didn't go to contact 1, we left it there and we plugged in contact 5. And upon initial stimulation, the flexor carpi radialis muscle was saturated with noise, and we ended up turning off the channel. Contact 5 elicits a response from the upper arm and the hand, and that's what you see here. No leg responses. We don't have the face turned on right now. Time base, I think here, this is actually 20 milliseconds of division. And I'll show you why that is later. It makes it more aesthetically appealing to the eyes because it looks like a good action potential here. These are very temporally dispersed waveforms. So when I first started doing this, I had a typical time base of whatever, 5 milliseconds per division or whatever it is, 10 milliseconds per division, end up with these elongated waveforms. And this just made it look better to me. And that's why it looks tight. But, these are coming, and these are going to come in, around 20, 30 milliseconds. Where a typical motor response would come in from the hand, for example. That's where these are going to come in. So we're looking at a 20 millisecond time base, 20 milliseconds per division time base here. So then next, the surgeon moves the strip posteriorly within the same plane, and no response is obtained from any musculature. So green is baseline, and then he moved the strip. We're still in contact 5. He moves the strip. We're no longer on motor cortex, and we get nothing, flat lines. Move the strip laterally and back over the motor cortex, and we end up with an upper arm response only. No hand, no lower extremities. Move the strip laterally again, and the surgeon requests the face be monitored, and he asks for contact 4, because the surgeon will guide you. Contact 5, contact 4, because he's looking at the strip. So contact 4 is stimulated, and a face response is obtained here. And at first, it was one of those weird things. We weren't sure if this was a phase response or not. And the only reason why we even called it a phase response was we were able to get it to go away when he moved the strip. But it's kind of this also temporally dispersed response. Again, the strip was moved laterally, phase response elicited from contact 4, with nothing else being elicited. Surgeon then requested stimulation from contact 6. Response from the face is subsequently elicited as well. Still nothing going on in the rest of the channels. Then next electrode is moved medially. A response from the upper arm and face are obtained by contact 2. So upper arm, and we still were getting the face. And this is where we ended up getting face, arms, hands, sensory cortex, motor cortex, central sulcus. What's wrong with this picture? How's the homunculus laid out? What's that? Hands and arms are backwards. Everybody's wired differently. So this is an interesting case. This patient is just wired differently. He had more hand function medially compared to his arm function, which was just him. And we confirmed this. I mean, we literally stimulated. This was probably 4 or 5 hours of stimulation and phase reversal, and just making sure we were getting responses. You're not seeing the entire picture here, but this was, I think we did this surgery, was like almost 20 hours. And this was, I want to say, this was maybe the 3rd surgery on this kid, because the first, they brought him in, initially when it happened, did a craniotomy, put the subdural EEG electrodes in, and then monitored him, and then brought him back, tried to do this by just trying to find the seizure focus, couldn't do it. Then they called me. I came in, we did the mapping, and we did all this, and it ended up being like a 20-hour ordeal when we finally got it up and going. And they ended up doing a hemispherectomy on this guy. Okay, so let's have some fun. Is there a phase reversal here? Is this motor or sensory? Okay, let's have a vote. Who thinks it's sensory? Who thinks it's motor? Yeah, it's all motor. Which electrode do you think is closest to central sulcus? Is there a phase reversal here? Motor or sensory? Which electrode do you think is closest to the central sulcus? Who said S3? Okay, let's have a vote. 3, 2, 1. Yeah, 1. 1's probably on the central sulcus. S1, S2, S3, S4, S5, S6. See? That's flat. So this is probably actually on the central sulcus. And this doesn't show up. I don't know why the screen colors. Can you guys see that at all or no? All right, so I'm going to outline this. Here's this is sensory only. And 6 is closest to the sulcus, but this is all sensories. Yeah, I don't know why, because on my screen, it's fine. Is there a phase reversal here? Motor or sensory? Make sure you guys are paying attention. Where's the central sulcus? Between, who says between 3 and 4? 3 and 4? Who says between 2 and 3? And 2 and 3 are the winners. Sensory, that's the beginning of a motor response. And then, so this is super close to the central sulcus, but not on it. It's just over the central sulcus on the pre-Rolandic.
Do you not get that much current spread that it would be that precise?
You don't get any current spread because this is a phase reversal and you're picking up from the brain. So the current's down at the wrist. Right. So that's why it's that precise. So here's another case study. Any questions on phase reversals, guys? You do enough of them, you get comfortable, especially when they do look like that. Sometimes you get really noisy ones. It becomes very difficult to interpret that and be like, oh, where is it, you know? But if you get them to look good, they're okay. So, so this one was a craniotomy for a midline parietal meningioma. Patient's 5'8", 224 pounds, 63-year-old male, presents with parietal meningioma. Patient is not cognizant, so not aware. The mass was discovered 1 week prior to surgery when the patient's gait became worse and the patient's memory seemed to be affected. Patient has a history of diabetes, hypertension, stroke 6 years ago that had no neurological deficits. Patient did have polio for a year when he was a child. It was in an eye or lung. The patient's left leg is smaller than his right due to the polio. Patient has no history of seizures. Patient is having issues articulating words. There have been no personality abnormalities. The patient has no paresthesia related to the tumor. Modalities utilized: MEPs, transcranial motor potentials, mapping of the motor cortex with a 1x6 strip electrode, transcortical MEPs with a 1x6 strip electrode. Tumor was midline, so we were concerned with the lower extremities more so than the upper extremities. In this case, I remember this surgeon never liked doing phase reversals. He would always just throw the strip on and run motor and map that way. The problem was that we would always get into quote unquote arguments over where the motor strip was, because he'd say, well, the motor strip is right here, but we're not getting a motor response. And I finally convinced him one day to do a phase reversal to prove the theory that you're not on motor, and it worked. So but he still didn't like doing it for whatever reason. So so we did some mapping with the direct cortical stim, and then we did transcortical MEPs throughout the surgery. So, reproducible transcortical motor potentials after dura is opened and a 1x6 strip electrode is placed, and the motor strip is mapped. So we've mapped the motor strip, we figured out which contact is going to be the best and where the motor strip is. So midline tumor, we're getting an arm, we're getting an upper leg and a lower leg. And you can see the responses pretty well here. This is actually 30 milliseconds per division on this screen. So, and I have and as you can see, these are coming in at the appropriate latencies for arms and legs. Remember, and these are, I know they look like sensory responses, these are motor responses. So just try not to get confused here with that. So, lower extremity SCSP at 12:37. The time is important. So the SCSPs are kind of crappy. Obviously there's no paralytic on board, so we're not getting any subcortical. Green is baseline. These are posterior tibial nerve SCSPs. The timing is important here. So pre-incision was at 10:17. This is at 12:37. At 1:16, we have stable MEPs, right? And it just so happens that our strip is picking up, we're more midline, but we are getting the arm, which is good. This is actually good to have, because you don't always get it. Sometimes if you're too far over, you'll get only legs. This case was we're perfectly able to elicit an arm. We're getting enough spread to elicit an arm and legs here. So here's the SCSP. This is the first SCSP since the last one was acquired. It's 1 hour. So we're continuously running that MEP throughout the surgery, but they're doing so much cautery that we weren't able to obtain any SCSPs for an hour. But they're stable here. And also, you got to keep in mind, too, guys, I forgot to mention this, when you're doing these types of surgeries, your SCSP placements, your true SCSP and transcranial motor placements might not be optimal for acquiring responses or stimulating, because they're cutting into where you need to place your electrodes. So you have to keep that in mind when you're doing these procedures. So that could be the reason why I have this one side looks amazing and this other side doesn't. It could also be the patient's, pathology and the fact that he had polio. There's a number of reasons why this looks like this and this looks like this. But just keep that in mind that you might not be able to get good SCPs on cases because of that. So we're continuously after they'll cauterize for however long. As soon as they're done cauterizing, boom, hit a motor. And we get stable MEPs. This is at 1350. And then at 1401, what do we see? Complete 100% loss of the legs. But the arm is still there. 1403, first thing I do is, can I run a sensory? I alerted the surgeon, run a sensory. Sensories are there. This is one of the only times you'll have an MEP loss without an SCP change. Why is that? Yeah, it's motor cortex. When you're doing a cervical discectomy infusion and you lose your motors, you're going to lose your sensories because 9 and 10, it's a vascular injury. In this case, there's no vascular injury here. This is a motor cortex issue. And the way you see this in spine surgery is typically, not saying it doesn't happen, but typically in like intradural, intramedullary, where you're actually near the motor tracts of the spinal cord. But in most spinal cord injuries that we see, they're going to be a vascular. It's going to be a ding into the cord where it creates, a spinal cord shock, which is, an ischemic event or something of that nature. But in this case, sensories are completely fine. So we told the surgeon immediately, and he stopped procedure. He stopped resecting. He decided to close. And look what happened. Came back. So what happened here was the surgeon had irritated the motor. This was a midline right within the motor cortex. He irritated the motor cortex. If we weren't on this case doing this type of monitoring, he would have resected the motor cortex. If we weren't doing these transcortical motors, he would have gone right through it, and the sensories wouldn't have told us anything. This patient woke up with no neurological deficits, other than what he came in with. Any questions? So I guess we'll take a break.